called Dorcus. I work as the Diocesan Health Coordinator, Diocese of Jinja. So I coordinate all the diocesan health facilities. Okay, the 3 clinics that you visited, the Diocese of Jinja is the owner, the legal owner of those health facilities. So basically what we are trying to do is to make sure that the services are offered in a quality way, and also we want to increase accessibility of services, and at the same time also respecting the mission of the church that we offer equitable services. Okay, first of all, the clinics, since they are owned by the diocese, one of the things that we do, you must make sure that your presence is there. So on a monthly basis, what we do is monitoring and support supervision. So sometimes we do actually hands-on training, hands-on supervision, and coupled with that, we want to know whether the patients are satisfied with our services. So we also carry out what is called patient satisfaction surveys to get the feedback from the patients to know whether we are really offering the services in accordance to what they need or not. The surveys we've been conducting, at first in the initial stages, we used to use what is called paper-based approach on the exit. So once the patients are being treated, then you can sample. You randomly sample as they go out at the exit and ask some few questions. So I can recite few like, did you take long to get the service? Were they kind to you? How was the environment where you got the treatment? Was it clean? If like you visited the bathrooms or washrooms, were they clean? Are you willing to come back next time? The medication, when they were being given, were you involved? So things like that, just to recite some few examples. So from there, also another important thing we will ask, how much did you pay for the service? Do you think it is worth the treatment that you received, or you think you paid expensively? So then we can also gauge from there, because these church institutions, the health facilities, we charge a certain charge from the patients. So it is good to understand, to know whether they are comfortable with the pay. Jinja Diocese, we are blessed. I think being the first one in Uganda, we tried to use another approach. In this way, it was like a threefold. One, we used the paper-based as usual. Then also we used the call, like calling a patient from somewhere else, which was being done in Kampala. And also we used what is called a smartphone, like mobile phones, where the questionnaire were already inbuilt, which were on paper, and also the call center was using the same. So we used that to ask the patients as well, to compare the 3 methodologies or approaches, which one could be more efficient, maybe cost-effective. And so I can give some examples, the advantage of using a mobile phone other than the paper. One, that we had bulk paper, so it could also take a big space because it is bulky. But the smartphone is something just small, I just put in my pocket and I go. And secondly, also another thing that when we used paper-based, the patients used to be scared, because sometimes when they see the bulk and you tell a patient, I have just 5 minutes with you, then just because of the sight of the papers, the bulkiness, he says, no, I'm quite late, and so they would be scared. And also another thing, so the smartphone is like, they are not seeing the question. So it's ready for you, because maybe the fact that it's small also attracts that maybe the questions are just 1 or 2. Then another advantage was that sometimes when you used to use paper, the data collectors, the spellings sometimes and incompleteness of that data. So sometimes you get incomplete questionnaire and the handwriting is horrible. So you have to take long maybe to enter the data. But in this case, once the data is entered, there is a inbuilt check, just that it will show you red. These questions have not been answered, please, they're important. So you remember that you've got to complete the questions. So so the advantage of our paper was that you must make sure that the questions are complete. Whilst the paper, once you are tired, that is gone, it is gone. They bring in complete data. The phones, I think, were highly appreciated. One of the things, again, is that in Africa, maybe we love just photo snaps. I don't know whether it is true, because there was another part you have to take the photo of the patient, and that one they loved it most. When we would take the photos, they would say, yeah, I think since they've taken my photo, they've taken my views quite important. So I think really something will be done because of what I've said. So it was like making them believe more that what I've said actually maybe will be heard somewhere and action will be taken. So one of the things that the data that we collected, one other advantage over the phone was that the analysis is very quick. So we could show to the patient, to the stakeholders, that is the patients and also the health facilities, that actually the feedback is here within the shortest time period. Unlike the paper, we could take long because you have to enter them, you have to analyze, you have to take long. So at times, even by the time you are disseminating, they have already forgotten. But here it is quite a shorter time, so they are still thinking, what about it? Then you go back. So they were really appreciating that the feedback was done. And it has helped the Jinja Diocese so much to understand whether the patient likes our services or not.